Good morning to the courageous participant in this Sunday session. We will be to the most famous session we can have in any meeting, which is the complication session. And I will replace as the chairman the master of this topic, Eric cath from Switzerland. I think Eric is online and will make the first presentation. Eric?
Yes, good morning.
Yves Louvard speaking. Good morning.
Good morning.
Very happy not to see you yet, but we hear you.
Yeah, I'm sorry.
Okay. So your topic is complication. Are they all the same?
Yes. Okay, can I start?
Yep. Yeah.
Okay, thank you very much for introducing me, Yves. I apologize for not being there, but yeah, that's the way it is. I'm going to speak in the next, I would say, 15 minutes about complications. Some of you may have heard a part of this lecture, which I tend to present on a few occasions. So it's all about complications that I'm going to deal this morning. And thank you to Nikolai for inviting me, and greetings to all the Bulgarian friends. I'm sorry for not being there. So this is a little bit the overview of what I would like to discuss with you. A few words about the basics, a few words about the actors, because we need actors to have complications, actors, patients, and physicians, the tools that we have to work on complications, and if there is time, a short bonus. So all that is on this slide, I think, is definitely true. Complications are underreported. They are underreported because we have a variable perception of what is a complication. I always elucidate to a big hematoma in the groin that can be a big complication for the patient, not for the physician. Often is not even mentioned on the cath lab report. There's also, I think, a scientific gap. That means that we don't really publish on complications, and if the data are published, not sure if what is there is correct, but there is certainly an important selection bias. I would even say more. I would say that there is lack of adequate auditing. We have some audits. I speak about Switzerland, but these are jokes, you know. Some guys from the Swiss working group interventional cardiology come by and look at a few cases, and then, oh, you're doing well. And there is a jungle of practice. We all know that there are too many stents placed in the world. It is the most common medical intervention in the world is stenting, coronary stenting. And there is a jungle of practice. Who controls who? So I think we really have an issue with that. And I'm not sure if this is going to change in the decades to come. Here are the issues related to complications: human error, device or technology failure, or I would say medical error. Let's focus first on human error. This definitely is human error. This is something we should not be proud of. This is a mitral clip pulled out of a patient, and you can definitely see that there is a part of the mitral leaflet on it. This is definitely human error. This is not the issue of the mitral clip. This may be something different. This is a valve where the balloon has ruptured, and this definitely is a device complication. And this is a little bit in between, I would say. This is a broken cath lab table. You can say it's the fault of Philips, but you can also say that when you have a resuscitation, you should put the cath lab table in the right position to avoid this kind of complication. This picture comes from the US, not from here. No comment at all to that. Human error is when something unexpected happens, the inability often to understand what's going on. And when you understand what's going on, you lose the global picture and you start to focus on one issue that you don't understand. And then things can happen. Communication can be suboptimal at that moment because the physician in charge of the patient is focusing on the thing. Then protocols may be lost, not compliant. And then a lot of things can happen, as you can see over here. And it is then the whole team that definitely, as often as the medical actor, is not working well. And I would say not to be rude, but it's something that particularly happens to younger doctors. It's happened to me when I was young. You're focused on it. This multitasking, which is definitely already an issue for male interventionalists, is a problem. Device or technology failure is uncommon in our practice. It is often related to the fact that we don't follow the instructions for use. You know, this big booklet, paper booklet accompanying any device, we never read it. And it can be that you are not trained with the device and you're missing expertise. But what I found is that this kind of complication can often be solved by imagination and creativity. Look at the Apollo adventure so many years ago, where basically the pilot, the astronauts and the team in Houston were able to bring back the capsule to planet Earth. So it's often abused and overabused in our practice. The most dangerous complication I would say is medical error, and I show here a few issues that I'm not going to go into details. There may be one thing, competition, and don't tell me it's not an issue. It's an issue in every country in the world. It's even an issue in every hospital, I would say. And then, for example, insufficient knowledge of patient records. How many times you are asking the nurses, which DAPT is the patient on? What is the creatinine value? So, and stepping out of boundaries is definitely an issue. So I would call this medical error. And this is now to talk about more the senior interventionalists. This is more an issue of senior doctors. They are so used to what they do, they don't think, and they can make an issue there. And compared to aviation industry, as you know, we stand nowhere. A few words about the actors. Well, when you're young, you are a trainee. So, and I always say to young doctors, if you want something, you should work for it, and you'll get it. So mostly, if you want to get there, you need to get there. You need a mentor. I think we all need a mentor. The point on dexterity is I talked about it so many years ago, and I was criticized on that, but I'm really definitely sure about that. If you have two left hands, don't be an interventional cardiologist. I would be rude to say that you can become a head of department, but that would be very unpleasant to say that. But you can go in other directions, I would say. Don't record this, sorry. And you have to imagine a career plan. It's important that you know what you want to do, and you have to have some particular fields of interest. Let's go to the teacher. Not going to go into all the details because I want to stick to my 15 minutes. Maybe a few points. Have been a victim of complications in the past. So I always like people who say, I never had this complication. And I always think you haven't done enough cases. I had a lot of complications, as many as you in the room, I'm sure, too. And then I think maybe the last point I wanted to make your attention on. Assured continuity in medical care. That means when you're not there, you think you're a guy that cannot be missed, things should go on. And when you're leaving, when you're retiring, be sure that you have assured your continuity. Very important. People who are frustrated and unwilling to share will not communicate, and they will leave a gap when they retire. This is unacceptable, and this is a failure in your career. A few words about the tools. Well, you need, a mentor is not a tool, but you need a teacher. I would say guru is a little bit overkill, but you need somebody. Textbooks, we need textbooks. Power training, I think that you should practice. We have now a fellow from Belgium in our hospital. He's in the cath lab every day from morning to evening. He's doing power training. Very important. Go abroad. I think you have to move as a fellow. You have to move. Web-based teaching, simulators. Simulators is becoming more and more important. I was a bit skeptical 10, 15 years ago, but it's really changing now. It's changing the landscape. And then, of course, learning by sharing, by courses, networking, and more. Of course, as I said before, homework and move. More and more, I would say that you can explore other places. We have been always trained to go, well, States is difficult for Europeans, but to move into big centers in Europe. But I just want to highlight that more and more Asia is developing. I have a particular interest for this region of the world, but there are centers over there that are just excellent. And don't forget Australia and New Zealand. Complications, well, PCR, we have worked a few years ago on this program that is now a little bit dead, but at least we worked with a group of people on this. And I'm always happy to see that people using it in courses and reflect on that. So I think it is not perfect. I think we could have done better, but we had to find the consensus, and we didn't always agree on how to manage certain complications. For example, stent loss. I'm not going to show this cartoon, but this basically shows how you can retrieve a lost stent, and it's just highlighting the alignment of the catheter. So First of all, retrieving a stent by this technique is not always that easy. I would say this is a little bit idealistic, but anyway, it's shown over here. And you see that they indicate the alignment of the guiding to be able to pull back the stent. You will see that in a while. Once again, this is not perfect, but it's at least an attempt to show you something about that. Retrieving stents is not that easy, I would say. Learning by sharing. So congresses, networking. Networking, what is networking and social media? You have an issue, you make a picture or a video with WhatsApp and you send it to your best friend across the other side of the world because you are having trouble with a complication. That's networking. Everybody is doing it. I do it when I have an issue, and I think we should do it. Morbidity and mortality meetings, that means that we should discuss our complications afterwards, our deadly complications, we should discuss them. And most importantly, we should discuss them with the nursing team. We lost a patient a few months ago with Yamane in a CTO, an elective patient. It took me more than 1 hour to debrief with the nurses who were crying after the case. So you should stay in the hospital and finish. Even if it's 8 in the evening, you should stay there and debrief. Very important. If you don't do that, you will fail, and it will not be accepted by the team. This is my additional slides. Basically, I have time. So I'm originally from Belgium, and this is a book on physicians. Top means super doctors, and it was released by television. Basically, the television filmed in a kind of reality show, Physicians at Work. And of course, this I know that this was a little bit not well perceived by the community, because why would one be better than the other, and why would one be a top doctor and the other just, I would say, first economy class or low cost doctor. So is it true? Well, something is true, I would say. Just look at the famous movie on the landing on the Hudson River. So I was told that one pilot out of 10 would be able to land the plane on the Hudson. And I think, unfortunately, in our job is the same. So we are not equal in front of complications. Some of us will get out of trouble. Some of us will just crash. And if we speak about crashing, this is a newspaper, and I was reading that, and I was really looking at it. It is about second victims. That means that when you have complications, you suffer. And according to this, at least to this article over here, 8 out of 10 physicians suffer from medical error. And this is an interview with a guy who is the dean of medicine in Ghent in Belgium. And he basically had to stop. He's a urologist, and he's specialized in transgender surgery. Apparently, this is complicated by a lot of diseases. At least there are a lot of complications in transgender surgery. And the guy went in burnout because of that. So I think it's an issue. And if I speak about that, burnout, you see it over here. This slide comes from Malcolm Bell when he spoke at our meeting in Lausanne on complications a few years ago, and it was about burnout. Now you may wonder where we as cardiologists are standing. And at least this concerns America, the United States, of course, not Europe. But as you can see, we are quite high. Once again, urology. Well, I just talk about the urologists, but urologists are standing quite high, and it's quite interesting to look at that. To look at this slide. This is my last slide, and it's a slide that's coming from Eddie Horek, who's a senior cardiologist in Cape Town, still working. He's 70 plus. And this slide shows you the relation between, he just draw it like that, between confidence and competence. And first of all, I think that lesions don't exist. Honestly, I don't believe in that. But as you can see, I always look at this part of the slide. I always look at this skilled and insecure zone. And there are people like that. And it's sad, but there are people like that. And of course, we have this and this zone. And cowboys are around, unfortunately. I think you all understand what I'm talking about. So to finish, my last slide, I think that learn well when you're young and teach better when you're older, I would say, senior. Stay focused and know your patients. That concerns all of us. Sometimes we treat lesions and not patients. There is the principle of do not harm. So I really think we have to respect that. It all looks so logical and easy, but why do we violate these rules every day? I would try to understand. Try to keep it simple. I'm sometimes impressed to see 4 or 5 viruses in a coronary and OCT. Sorry, sometimes I don't get it. I just don't get it. Because time is complication. The longer the procedure, the more you expose your patient to risk of complication. Don't compete, but cooperate. I talked about competition before. I think it's important to highlight that again. And maybe the last slide is learn from your mistake and don't repeat them. So if you have been repeating mistakes a few times, then you should question yourself. There is something definitely wrong with you. So at the end, I don't want to be too negative. I think we have an incredible job. We are very fortunate to be interventional cardiologists, and it's an incredible moving target. We have a big community where we enjoy meeting each other at meetings like the meeting in Bulgaria. So thank you for your attention, and I wish you a good meeting and a good case complication discussion later on. Thank you very much.
If there is any question to Enrique Kaut, I have one. Is do we do enough in our institution? I mean, EAPCI and our meeting leaders to focus on complications, or are we waiting for more regulation coming from our states?
I think we do quite enough. If you look at PCR, there are a lot of case sessions now, and it's mostly organized. As you can see, mostly they put countries together in sessions and then they present complications. The only concern I have with complications presentations is that we tend to show how good we are. And I think we should show the of course, if you have a complication with a guy who has a really great idea and really solves the problem by solving what we learn from, that's fantastic. But what we should really show is the complications, the root complications, not the complication that highlight the individual person who is the interventionalist, but highlights the real complication. That's a little bit my concern when we see complications.
But we still see in some meeting, I mean, probably the most technical ones, like in complication or in CTO, we see sometimes practice that are, for me, not acceptable. You know, that demonstrate, that they are the best, and something which is not published, something which is not validated. Of course, we still see that in Congress.
I think is a difficult animal. I would say I think guys who don't love CTOs, I think we all love CTOs and we all love to do it, but we always have to question ourselves what we are doing is right if they have a good indication. The point is that there is a big industry behind CTOs and there is still a lot of money. CTO meetings, they have money because the industry invests, because CTO is really that field where companies can explore new technology. Because there's not a lot. What do you want to say about stents? We have 4 to 5 generation of stents. There's nothing that's going to change in the future. BVS didn't work, but CTO technology helps us to progress PCI technology, and so that's, I think, is an issue. But definitely we have an issue with some presentations of CTOs. But I think we just have to live with it. We don't have to go to these meetings. The only thing we can do is gently discuss during a case without offending the operator about the indication and the practice. If it can be done in a constructive dialogue of criticism, that's probably the way we should do it. Yeah.
Yes. Any question? Any other questions?
I don't have any question. I want to say.
I have a specific souvenir which was a long time ago for PCR transmission. I had a dedicated bifurcated stent to implant in a coronary bifurcation, and I have tested this model only one time before the PCR, and was a terrible mistake because in fact I was unable to deploy in the bifurcation. I have to remove with a snare. So this is typically for me something that has to disappear. If you are contacted before a live transmission for a big meeting by a company, example, a PCR at the end of April, I think it's a mistake. You have to say no to receive the device in January and test repeatedly and then present the result. And this is what I mean when we maybe in technical meetings, it would be better to develop what company wants, testing of new products and new strategies, but in small group and not be demonstrated until you have a validation of the technique. So I think evaluation of a new device in your cath lab or in several cath labs, but not in meeting, collection of data, publication, and then demonstration. So I think we cannot demonstrate in meetings a material you receive the day before. I think this is not fair for the patient. So this is the kind of rules that can be, in my opinion, introduced. In our place now, in Massy, never we take a material after beginning of March. No. Thank you, Eric. I think
Thank you so much.
You still speak a bit later, no?
No. I'm going to the airport.
So it was.
I want to
nice
say
to
just
see,
thank you for support to Professor Cath, and it was a pleasure. Thank you.
Pleasure.
Thank you so much.
Have a good day, everybody. Bye-bye.
See you.
See you.
Bye.
You can proceed
Go.
with the first presenter. It's Dr. Dimitrov, and his case is double trouble in the cath lab. The floor is yours.
Good morning to everybody. I would like to thank the panelists and the organizers of the 11th meeting for the opportunity to share this case, which is a complication case that I had 1 year ago, and unfortunately up to this day I'm not quite sure why it happened, so maybe I could use some of your insight. So my case is about a 71 years old female patient that was admitted to our hospital with newly onset of chest pain for 2 weeks. Previously she had heart failure complaints for several months. Her comorbidities were arterial hypertension, hyperlipidemia. She was with permanent AF with anticoagulation treatment, and on her physical examination, pulmonary rales and peripheral edema were noted when she came. On her ECG, her laboratory findings were normal. On ECG, she had ST depressions in the infralateral leads, echocardiography, mild mitral and aortic regurgitation, but severe tricuspid regurgitation with pulmonary hypertension, enlarged right cavities. Her ejection fraction of the left ventricle was normal. So this is her diagnostic angio. You can see the right coronary quite normal. On the left, tight severe stenosis after the diagonal. So we performed right heart catheterization and oximetry run in order to exclude ASD, that it was excluded. So we offered her surgery because of the heart failure symptoms and severe tricuspid and moderate mitral regurgitation, plus one bypass, but she declined. So I decided to perform ad hoc PCI of the LAD with an Orsairo stent 3.513. You can see the placement here. I decided to keep it simple, not to protect the diagonal since it was free of disease. Inflated the stent. So this is my result. At this point I felt quite comfortable. I thought that everything is okay, everything is done. And I took off my gloves and went to the computer. Unfortunately, as the nurses took the sheet out, my patient became pale and hypotensive. She complained of severe chest pain. On the ECG, since she was still on the table, ST elevations were registered, so I immediately rushed back in, obtained a femoral access, and a new angiography was performed. I had an acute stent thrombosis. Immediately I took another guide, placed a run-through wire through the stent. I tried to place it, but unfortunately, for some bizarre reason, I was not able to easily navigate through the implanted stent. So after several attempts, a knuckle was formed just after the stent. So I thought at this point that I had been subintimal. Then the first cardiac arrest happened, the CPR was started, and after that I decided to use the parallel wire technique. I took another wire, pivot 50, in order to insert it again and to try to restore the flow. Unfortunately, the second wire still would not go through the distal through lumen of the AOD. So at this point, I saw that I had not only thrombus, not only probably dissection, but an extravasation. So I felt quite lost right now. Another ventricular fibrillation, CPR, which was successful. And at this point, I knew that I was not going to be able to place another wire. So I used the first wire to re-enter distally. With a thrombus aspirational catheter, I was able to go into the true distal lumen distally in the AOD. I was very lucky. And after several balloon dilations, I was able to restore the flow and implanted one stent, which sealed the extravasation, and distal flow was not very good. That's why I decided to place another stent. And this is my final result. Telemetry flow was restored. I was in the true distal lumen distally. So the patient, actually, I forgot to say that actually I had another problem, which I saw later. During the first CPR, my pivot wire went into the first septal, and unfortunately it ruptured it. But since it was in the myocardium, on the echo, there was no effusion. So I tried for several times to seal the puncture with balloon inflations, but unfortunately I was not able to, and I left it like this. The patient was stabilized and went to the ICU. She gradually recovered. She left the hospital on the 5th day with triple therapy, now with a reduced ejection fraction of 40% with large anterior hypokinesia. During the follow-up, she was unfortunately with persistent signs of heart failure, despite her optimal medical therapy. That's why on the 6th month, I decided to check again what's happening. And unfortunately, I had an occluded stent. The second stent was occluded just before the overlap with the third one, and I had an apical aneurysm of the left ventricle. So again, I spoke to her, and since she now has severe mitral and tricuspid regurgitation and mild to moderate aortic regurgitation, I decided to offer her again surgery, so she agreed. And I sent her for surgery for the 2 valves to the mitral and tricuspid, and one bypass to the first diagonal, since it was ostially, it was stenosed. Maybe there was a plaque shift, I don't know. But I specifically told the surgeon not to operate the AOD because I felt that there was not a viable myocardium there, and there was not enough of the native AOD left because of my stenting. Unfortunately, the surgeon performed aortic valve replacement and did endarterectomy of the AOD, managed to take out the last stent and grafted the lima to the AOD, which prolonged the cardiopulmonary bypass quite a lot. And he did not reconstruct the AV valves for some reason. Unfortunately, the patient developed cytokine storm and severe shock after that and passed away 5 days later. My take-home messages for me from this case is that maybe maybe we all should pre-treat the patient before we start the PCI with antiaggregants. Not that it would have helped me here, but maybe it's a good idea. Fear of complication is healthy, but panic is lethal. If I was so shocked and stunned that I had such a acute stent thrombosis that I was so aggressive and rushed to save the day with the wires. And if I had stopped and had a second thought, maybe I wouldn't have been so aggressive. And excessive stenting should never be performed, because if I had left the distal AOD without a stent, maybe the surgeon would have had a place to place the lima graft. And maybe we should all teach our colleagues humbleness and not to show off with the stents that they take out from our patients. And again, no matter what is the severity of a complication, one must remain calm, regain confidence, stop and think for a second before he rushes to save the day aggressively. Thank you very much for attention.
Is it possible to see the very beginning of the procedure?
Yes.
Can I ask something?
Yeah, of course.
What was the antiplatelet therapy and when it was given to the patient?
Since she was with atrial fibrillation, I had to leave her on aspirin and clopidogrel.
No, I mean before PCI.
I didn't give her anti-aggregants before the PCI.
This is elective patient?
No, it's a...
This is STEMI.
No, it's not a STEM. It's not an... it's an unstable angina.
Unstable angina, that means that there is no positive troponin?
No, no.
No troponin?
No troponin.
No ST elevation?
No ST depression
And
syndrome.
you start PCI without antiplatelet treatment?
Yeah, this is a mistake, obviously, maybe. But if I had...
Nikki's...
I disagree. We can
I
start.
think that the case is a clear demonstration why it should be done and why this is written clearly in all guidelines.
Yeah, but
Clearly.
my explanation here is that if we can see the very
We can
beginning,
come back,
that
To have what are
The fact that
the
the
possibilities,
second
yeah.
stent thrombosed, that means that there is a huge chance that this patient is clopidogrel resistant. 23% of Bulgarians are clopidogrel resistant. These are data which we had in National Heart Hospital more than 12 years ago in a huge population of people. Really,
but-
this is this situation in Bulgaria.
yes, we know we don't need to test this kind of patient. All
You
the
made
trials
a
are
PhD
negative.
on this topic.
that's why
Your
I'm-
PhD is
Next
on
one.
this topic.
Yeah, but it's about the acute coronary syndrome, and we
Next
don't
one.
need to test this kind of patient.
Stay here.
Yeah, but
So
let me say something.
Yeah.
We should be patient. It's really brave to present this kind of cases. We should learn something from that. Not this is your mistake. And
Unfortunately,
stop.
she was
Do
with
it.
atrial fibrillation, so I couldn't give her ticagrelor or prasugrel after that. Because
Why?
she had to take anticoagulants.
Because of atrial fibrillation.
She's with atrial
Actually,
fibrillation.
if this is a patient from 1 year before, if you open your guidelines, it is written that in general you can give ticagrelor for this patient. Only ticagrelor, you can leave the patient for 1 month on triple therapy, even this is class 2B indication, and after this severe complication, I personally will never, ever leave such a patient on a clopidogrel.
Maybe I will do this, like you, from now on.
Yeah, but
I agree with doubling ticagrelor and anticoagulation. Okay, but I want to raise another hypothesis. You see on the right side here. First, you have that's not the source of the problem. There is no wire in the diagonal.
There's no way.
Yeah. So this is a mistake for me, really, because you never know what can occur. Having a wire give you the possibility to re-entry much easier in the occluded vessel. So, but look at the end of the stent. You see this. My opinion is that I'm not doing IVUS, but an IVUS will show a dissection there. So this is another option.
Yep.
Another problem is that probably this is...
The end of the stent is not managed properly. Either this is a residual stenosis or this is a dissection. But maybe you have to do something. Look, or even see if it can be corrected with a balloon, or even take the decision of putting a second stent.
and so
Just a second.
there is a one
Maybe
very,
I'm wrong, huh?
very
And after that, of course, with a double stent, a triple stent,
and
the
other thing
problem
that
of the thrombotic problem occurs.
we don't have a well expanded stent because we have a bifurcation. We don't have a pot, and probably we have a no well expanded stent in the proximal part of LAD. Another option is on dissection.
There is a comment.
Yeah.
There is some clear undersizing of the stent. Why? First, it is visible that the mid portion of the stent is clearly with the less diameter than the ends of the stent. So the second point is with this shallow angle, there is no almost any carina shifting, which means that there is no displacement, any displacement, and stent is hanging into the lumen, at least in proximal and distal parts for sure. If you see such a picture, this picture is very teaching, I think, that this picture demonstrates if you don't have a pinching of the side branch with such an angle.
I have a pinching here of the osteodiagonal.
No, I mean
If we
the
go back to
stenosing. There is no stenosis in the osteum of the side branch after
it's free of disease.
stenting.
It's free of disease before, and now after the stent, you can see here on the.
It looks like
I strongly
You can see that the
recommend you
ostium of the diagonal has
to read
pinching.
the last 3 European bifurcation statements about the mechanism of side branch compromise. So this side branch is not compromised after stenting with this shallow angle. This means that there is no any deformation of the vessel from the stent, who is hanging proximally and distally.
So for me, a slightly longer stent, maybe with 2 diameters. I mean, distal to the diagonal is probably too big. That generates this picture at the end, and when a stent is too big, can have a dissection. The one you don't see. And do a pot to have clearly a triple diameter. This changes completely the flow.
Yeah,
Huh?
for sure, for sure.
So there is a comment there.
Yes, thank you. First of all, maybe the first thing that was supposed to be done, predilatation here. Because after the stent employment, you can see the blurring in the stent area. Actually, I don't know what's happened in the arteria there, in the proximal part where the artery, where the stent is, but it's like blurry. And after the stent implantation, you see the flow goes down TIMI2. This is not TIMI3 flow.
Where?
Into the LID.
Oh no, it
No,
was
it's-
Timothy.
TIMI2, 3.
No, it's 3. Believe me, I had several other projections that I didn't
And
place
you
here.
can see that the shape of the artery where the stent is, it's not with a sharp or right smooth edges. I mean, from this point of view.
Okay, but
Maybe the predilatation would do something else, I don't know.
Maybe I should have done pre-dilations, but
And I think it's the
but
dissection-
stent was implanted without a problem. There was no dog bone. I don't know. Maybe
well expanded
maybe it
stent,
was a
it's
good
fine
idea.
in general.
So 2 wires, stent chosen from distal diameter. More probably you won't have this distal lesion and pot. Probably after that, and you have seen occlusion, you have to put. It was difficult to open. You put stent.
There is one very easy way to know did your stent is well opposed. Place always a wire into the diagonal, and after stenting, just pull this wire. If it moves freely, that means that at least from the carina behind, the stent is not opposed.
Yeah.
Very, very simple rule, which will save a lot of nerves and adrenaline in future. Believe me.
Yep.
And for the rest, for the perforation, I think it's a bad combination of not well expanded stented, aggressive wire, polymer
I was
jacket wire.
I was too aggressive.
I would not care about this perforation. This
Me
is
neither. Me neither. But
The septal one is.
this
It's
is
fine.
in septo.
yeah.
Just
we just need echo to be sure that we don't have septal hematoma. That it's only problem, potential problem.
Yeah, but
Even
what
the
do you do?
septal
What do you do with
hematoma is
that?
not so.
When there is the septal hematoma, you look at the septal
Just
hematoma
look
for a
at-
few days,
Yeah.
and normally this is disappearing. So.
Fully
Okay,
agree.
this is
Excellent
this
case.
is interesting, and this is brave to show that. I
Thank you.
remember I presented even worse case like this, and you learn, and you learn, and next time you will follow. This is a simple bifurcation, so we'll do simple. It's too simple.
Yeah.
Okay.
maybe that's my problem. I underestimated. I was like,
maybe reaccess through the for me was a dissection. No? What we see immediately after stenting is a dissection. Try to reaccess with the soft wire, but also take care of some soft wire. I would say filter XT to try to re-enter, not the stiff polymeric.
Yep.
Because these ones, they can go everywhere, you know. You just push, or they can go alone even, you know. And you push in the wall, so.
Thank you so much.
Mitko, may I ask something? Thank you for your case. It was very good. I mean, it was bad, but we can address other things. There are mistakes on different levels, so we don't have to rush when we have elective patient, especially without DAPT treatment. So we have to stop the procedure, explain all the different parts of it, and preload the patient. After that, do the stenting electively. And the second part, there are, let's say, mistakes on the next levels. I mean, for the operation.
That was a clear mistake.
Because, in fact, this was your case and the case for the cardiac surgeons who did not the job. So we have to stop, think, and after that perform, especially when we don't have to rush. So thank you for your case.
Thank you.
Very good point. In our place now, as we are doing mostly radial and mostly outpatient, we stage. If the patient is not unstable, he comes for coronary angiography. We discuss the case and we give a rendezvous for the treatment. So when the patient comes back for PCI, he has already antiplatelet treatments in several days. Huh? That's another point, which is okay. So
Yeah,
thank you.
Thank you
very much.
I would like to invite the next speaker. It's Dr. Nikov. And his presentation's title is When Things Go Bad to Worse. The floor is yours.
just a suggestion to Dublin. You know, I understand my young colleagues here, they are maybe afraid to present complication like this. So if you invite me next year, ask me a terrible complication I will bring and show that everybody can have a complication, okay?
Don't worry, I prepared 2 of them.
Yeah.
I will be next speaker after him. So, yes, there is no in the program, and exactly this is why I just wanted to tell you about.
Please.
First, thanks to the PBC committee for accepting my late presentation on short notice. And it's been always a great pleasure to be here in Bulgaria, in Sofia, with such eminent cardiologists like you. Today I will present a case when the cath lab goes from bad to worse. The patient was a female, 71 years old, 65 kilos, 168 centimeters, smoker, and diagnosed with schizophrenia 10 years ago. She was hospitalized at the internal medical ward with 7 days ago with small elevated value of the troponin and the ECG changes. So the doctors referred to the angio team, and this was the ECG. You can appreciate that it was somewhere at 7 o'clock in the evening. The ECG, you can see negative T waves in D1, AVL, V4 to V6. The patient at this time didn't have any chest pain. She was hemodynamically stable, and during the discussion with the doctors, she was going all the way in the ward, smoking cigarettes in the cafeteria, in the toilet, even in her room. So we decided that because it was 7 o'clock in the evening, the patient was stable, no chest pain, no symptoms, we decided to take it slow in the next day in the morning. So we do the diagnostic coronography and decide what to do next, because we have a schizophrenic patient that probably won't take the DAPT therapy and such kind of problems. So we do the ultrasound. You can see there is an ejection fraction around 50% with some light anterior hypokinesia, some calcified mitral ring, and calcified carotid arteries without significant stenosis. Later that evening, around 10 o'clock, 10:30, the doctor again referred to the cath lab team that the patient this time had a sharp chest pain that was persisting, and the level of the troponin is doubled since later that day. So we decided to, because of the growing troponin, persisting chest pain, to go to the cath lab, and the idea was just to do the diagnostic and contact the cardiosurgery team and discuss what to do next with the patient. So, why it's not moving? I have my laptop there, if it's possible. Sorry.
Presentation. Къде? Като ще правим презентация, трябва да...
Спирам монтера discussion.
So, we did diagnostic angiography, and when I saw that the right coronary artery was completely healed, I changed my politic to go with the guiding catheter left, not to do the diagnostic, because I thought probably the LAD in some medial section is stenoided, and we will put the stent and continue later with everything. So, I took a guiding catheter because this is a cath lab that is in the other city, and we are covering there as night shift doctors. The materials that are in the cath lab are bought by the doctors that are in the hospital. We don't choose the materials in the cath lab. So this guiding catheter was have the curve as a extra backup curve, but it was not launcher. It was some other bulky, sharp, and very stiff catheter, and it was very bulky to control it. So you can appreciate the short left main and deep super selective cannulation to the circumflex. On the right picture, you can see that how deep the catheter is in the circumflex. So because the LAD was not showing quite good, so I pulled back the catheter, rotate, so I can be super selective in LAD, and this happened. A dissection, spiral dissection to the LAD circumflex, and a retrograde back to the aortic root. And this was the nightmare that started at 10:30 in the evening. Change of plan, the patient went to the cardiogenic shock, hypotensia. We started with inotropes, adrenaline, dopamine, and changed the strategy. I took 2 BMW wires, make the knuckle, and lucky for the patient, lucky for me, the wire went directly to the probably straight right lumen. And this was the situation in which we, at 10:30 in the evening, alone in the cath lab, happens. So in this point, I decided to stand the circumflex in the medium part so I can restore the flow there. And I put the 3.532 millimeters on 14 atmosphere stent. And at this time, the pressure started to rise. We have the stabilized patient. You see, I put the stent in a left main LAD, but at this time, the patient raised the pressure, and I was afraid to put the stent in the left main LAD because I was afraid the flap from the dissection may close the circumflex, and we will start all over again. At this time, we have 2 or 3 times DC shocks, and the patient actually was, as I said, schizophrenic. She was trying to stand up from the table, and we were fighting with her during all the intervention. So next step was I decided to put the stent in LAD mid so I can see if the flow will restore to the LAD, but there is no flow to the LAD as you see because the flap was spiral from the left main to LAD, and the next step was be brave or go home. I put the stent in the left main LAD, and you can appreciate that the flow was restored to the LAD, but the flap compromised the ostium of the circ. I continue to stabilize the LAD. I put the second stent in the LAD proximity region, and I received the TIMI3 flow through the LAD with a large and a lot of septal branches. At this time, patient was stable. Everything was going quite good. So we made this is the caudal projection. You can see that the flow to the circumflex was going down from TIMI3, TIMI2, TIMI1, and there was no choice then to continue with the third bifurcation technique stent, and I choose to go with the top. Before this, because not all projection were filmed, I do the pot first here, and after it rewire, kiss, and put the top technique for the stent in the CX ostial. This was after the rewiring, the pot, kiss, and this was the final result. In the final result, we received TIMI3 flow, again the stenosis in the circumflex in the mid region, large marginal branch, and dissection that was retrograde to the aorta was caught up with the stent of the left main. So take-home message is always know the material is good when you work, especially with this kind of, I don't even know the company of the producer of this guiding catheter that I was using at this cath lab. Be careful with the pressure when you're giving contrast, because we give on the manifold by hand contrast, probably the deep cannulation, the catheter was pressuring the ostium of the circ, and I was probably trying to optimize the flow to the LAD to put contrast there, and probably make the high pressure on the manifold. I make the dissection and always place the guiding catheter in a lineup with a cannulated artery, and otherwise you will go in deep problems. Never do any step further than the previous plan. Probably if I do the diagnostic of this patient with a diagnostic catheter, I would never going to make this spiral dissection, and probably we will see that there is a stenosis in the circ mid. Probably there was some stenosis in LAD, and I will refer the patient to the cardiac surgery team, and everybody would be happy. And when you work in a cath lab, always pray for less, but be prepared for the worst scenario. So I'm working in a cath lab since 2010, and this case bring back me in time when I was starting with interventional cardiology, and we always have to remember how it was when we started. So thank you for your attention.
Nice case.
Excellent.
I am shaking now because of the case.
By the way, I saw absolutely identical case in 2007 in Lublin when I was a fellow in Poland, and Tomek Kuławik, I just was looking for the Robert Gill. At that time, Tomek Kuławik was the chief of the cath lab, of his cath lab, and he had absolutely the same complication with one-chair catheter. So don't be worried, you can dissect the left main in the aorta with every catheter. And he won with this complication the competition for the best worst case on the meeting.
I had also something like this. I think it's interesting to make it was at the time we were beginning of transradial approach. We were trying to find a kind of multi-purpose to have time gain. So we chose to test emplats for left and right. Of course, I had some right coronary dissection, and one time I had the dissection of the left main. exactly the same, completely closed. And the conclusion we had, we collected a few cases like this, and with Thierry Lefebvre, we wrote a paper and we said, the first thing, if you have nothing inside, no wire inside, the first thing to do is to change your guiding catheter, change the shape. So we changed the shape, and was for an EBU. We went back quite easily in the two distal beds, and it was completely reconstructed. On the difference with you is that, in my opinion, you have to go from proximal to distal.
Yeah. That was, but I was afraid because when I put the wires, I saw that everything was disaster. Quite disaster.
Of course. But
and at that time, I thought that if I catch the flap in the medium of the circ, I will probably restore the flow. And probably, but I was afraid to put the stent in the left main LAD because I was not sure that I will rewire through the left main to circ. And it was quite a large circumflex artery.
So, and we said also that the best solution is to ask your nurse a big stent, big long stent, and stent towards the biggest vessel immediately. From left main to LAD normally, but the circumflex was very big here. So you know, we cannot have a big population to make more recommendations, but
we hope we won't have it.
Yeah. No, it was well done.
Thank you.
Okay.
Okay, to move further.
Other
It's
comments?
Yes,
changing in a program.
just one interesting case from this Monday. Just, I think that this case is very teaching. This is a 61-year-old male with a history of previous MI, with the primary PCI of the right coronary, and stents in the circumflex, and LAD, left main LAD. And he was coming back for control IVUS of left main LAD because of some angina, and he had a positive stress test on echo, exercise echo, so on the arterial wall. This is the ECG. There is nothing special. The patient was diabetic, is diabetic, not was. Is diabetic, and this is the angio from the previous intervention. There was a lesion on the osteo-LAD, and on the, just I will go back to see the previous situation. So on the right, you can see the situation after the, this is after previous stenting of the left main up to the ostium. And there was a residual stenosis on the LAD diagonal just before bifurcation. So the patient came for control angio, and because of this residual stenosis of LAD, we decided to do this IVUS and to see what happens in the LAD. There was a visible, there was a visible protrusion of the stents into the ostium of the left main, and you can see that the operator has quite a significant difficulty to wire properly the ostium of the left main. And then this is after several attempts, after jailing of the of the first wire into the ostium of the stents into the left main, and after pulling back the wire from the jailing of the wire into the ostium protruding struts. So there is a clear compression. There is a longitudinal compression at the ostium of the left main. The first wire was passing by. The second wire was trying to pass there. And here, I think this is quite a interesting. Yes.
If you look at the stent here, you see the dark dots. There are several small dark dots.
It
You
is
see?
compressed.
This is
because
typical of compression.
Absolutely.
This is overlapping struts.
Yes.
So despite even with we don't need if you have a good angio, you don't need an IVUS to see that. It can be diagnosed just looking what you see the dot.
The point here is that any balloon could not pass. This is and the stent is compressed. If you look carefully, this is the 1.5, the lowest profile of this alveolar balloon. This is as a Tazuna, and you look carefully at the place of balloon marker. The stent is compressed because of the several manipulation. The stent is compressed after the ostium, just with because of the wires, and we attempted several times to wire. This is ultimate wire, run through, hydrophilic. Anyway, finally we gave up. We placed the 2 wires and decided to crush and to restent the left main. This is може ли да не ми пипате слайдовете? This is a situation, and after this kissing with 2 3.5 balloons, we made an IVUS. Finally, we could pass with the IVUS in the left main. And this here, unfortunately, I cannot. Може ли да върнете предишния с този филм да пуснете? Да. And да. This is into the stent. It is lumen view from the IVUS. This is a high definition IVUS, and this is why we and you see the compressed stent struts. Само ще ви кажа. Stop. Just before you see the stent was compressed to in direction of the aortic valve. So we continue with we restented and reballooned the left main. There was a dissection distal from there was a stenosis there into the left main, and we used Godzilla because the stent I tried carefully to place a stent, but it was not successful because it was catched from the tooth from the previous stent into the ostium of the left main. So over the balloon, we placed a Godzilla up to the distal edge of the previously implanted stent. We restented distally, then restented in the left main. Pot, kissing, pot, and we made the final IVUS into both directions. So this is the IVUS, just to be sure that now everything is covered and everything is, the stents are completely opposed, that there is no residual dissection, because I was really afraid to leave the distal edges of the stents because of the multiple balloon inflations. And we were happy that practically everything was well opposed with the acceptable minimal lumen. You see the hematoma into the vessel wall, which was a spiral hematoma after multiple balloon dilatations. And that was previously from 6 to 12 o'clock. But fortunately, everything was well opposed, and we just left the crushed stent just to ако може да спрем картинката е тук. Тук, да. Just below the stent, at this point, If you look carefully, there is
Yeah,
a.
we see.
This is the, and on the left is just below the stent. This is the protruding previous stent. However, it was very well compressed. So my take-home messages is that you can mess even the already made well previous job just because uncareful manipulation with the stent, and you can make a really significant complication because this patient, the future course of disease, I'm not sure that will be very fortunate with such a number of stents, but we will see. And the other point is that you should not leave the stent to be hanging too much into the aorta. This is the positioning of the osteostent previously should, maybe it was necessary at that time to be much more precise. And to just to think for the future, because I saw a lot of times when you place a stent at the ostium, it looks good, but okay, that patient could return in future, not with you, but with your colleague. So we have to think that what will happen in the future with this stent. So that was the complication which I wanted to show, because it was very teaching also for me.
Just a point. I said yesterday that Akiko Mayara did a study on this problem in Excel.
Yes.
Was a systematic review of IVOS, and she found that the mortality rate was increased when you have this kind of distortion. But it was mainly because most of the distortion were not seen by the operator. What is missing is that is there a higher mortality rate or a higher complication rate if you are seeing the distortion at the time of the procedure and if you correct it. This is something we don't know. But it will be interesting to see if properly treating this kind of complication can save the number of mortality and complication later.
To be honest, this is my third case with such complications. And I have 2 previous almost identical cases.
We have collected more than 30. So.
Okay, but maybe we started later and we were learning from you. This is why. Yeah.
Just to stress this very important point that if you stent the ostium of the left main, you shall finish with IVUS to be sure that you're not protruding too much and you have a good position. Because it's funny, but it's also a problem for a surgeon. If a surgeon has to operate on this patient, it's a very big problem to give a proper cardioplegia inside the coronary artery. So having a stent in the ostium protruding is not also just the intervention cardiologist problem, it's everybody's problem.
Absolutely agree. This is why I'm showing that, and this is why the last sentence was that we should be very careful when we position our osteostents, and we have to just think for our future colleagues and for the patient, because even with the best result, without any restenosis at that point, but hanging stent, and because this is a left main and our threshold to do re-angio is very low in general. If you have a stented left main, the patient has some chest pain. At the moment,
sorry, that would be my second question, because nowadays you have a very good CT machines available. So what do you think for patients like this is nice to have a CT angio follow-up or just conventional angio follow-up?
This is what we are doing because we have a machine and a specialist from the last September. To do CT, it sounds good, it sounds great, but you need 2 things. You need a dedicated machine with a program for this, for the software, and for the special capabilities of the machine.
And the cardiologist.
And the cardiologist, who is trained to do that, because I can show you a lot of coronary angios done, CT angios, which are practically unreadable if not performed well.
Yeah,
you need a protocol, you need synchronization. This is not so easy to do.
Also, yeah, that's a good point.
It sounds good, but
nothing to see with this. But it's a good point to. In our place, we have now CT scan and MRI, and they are managed by cardiologists exclusively. And this is especially important when we are planning the treatment of a patient, following the data, because radiologists will say I find the stenosis, but they won't give us the information we need to treat the patient. That's the point. So I think this is important that cardiologists, young cardiologists, you can do both MRI and interventional cardiology. I was doing that for years and years. You can do CT scan and interventional cardiology. This is possible. And this is useful.
Yes. If you have a machine and if you have a colleague with expertise in this, then yes, absolutely agree. This is the method of choice from now on.
Okay, thank you. We need to move